go. Awesome. Okay, well, I'll do the introductions, and then by the time people start rolling in, I'll be done and you can take over. So I just want to say welcome everybody here who's joining right on the dot at noon, and welcome to the April History Rounds. Just wanted to start today by officially acknowledging that those of us attending from the Kingston area are situated on the traditional Anishinaabe and Haudenosaunee territories. And I'm always like, think about this time as an interesting time, the transition time of year, just from spring to winter, snow on Sunday, people swimming on Wednesday, and all the students leaving. And just think about a time for reflection and gratitude as we think about of transitioning in our own lives. And just thinking about all of those who come together at Queen's to learn and through diverse lenses and experiences, and just thinking about how much we appreciate the diversity all the students bring to the Queen's area. And just wanted to say thank you to everyone. I know this is lunch hour on a Friday, and coming together and to think about how we consider our research at HSPRI can support principles of equity, diversity, and inclusion. And really excited to hear from Suzanne and Connor today, and think about how our OHT uses these principles to inform the work that we do in building the health system, and the talk about through evaluation and some of the data tools that they'll be using. And just so grateful that Suzanne and Connor are here today. Connor's the performance and evaluation lead here for the FLA OHT, and Suzanne Pashley is the data analyst. And if people don't know them, they are just two incredible resources that we have here in our region. And not only are they incredible in terms of driving how we use data to inform some of our health policy decisions here, but truly they are considered leaders in the province, and people turn to us and them for their support. So thank you both for sharing today all the work that you've been doing, and I pass over the floor.
Thank you so much for that great introduction, Catherine. Bear with me as I set up the slides. Okay, everyone see my screen? Perfect, I see some nods. It's awesome. Okay. So before we get into the specifics of our work, I want to ground us in the broader provincial context and why primary care has become such a major priority in Ontario. Back in 2019, the province introduced the Ontario Health Team model. The idea behind the OHTs was to bring together different healthcare providers, such as hospitals, primary care, and home care, and have them function as one coordinated team. The goal was to make care more connected for patients, no matter where they entered the system or who they see. Fast forward to January 2025, the Ontario government announced a new primary care action plan led by Jane Philpott. This plan set a very clear mandate: ensure that everyone in Ontario is connected to primary care. So when we talk about the work our OHT is doing, it aligns directly with these priorities and contributes to the broader system transformation Ontario is aiming for. So now I want to take a moment to discuss our OHT specifically. We're made up of over 85 health and wellness organizations across the region, spanning primary care, community support services, mental health and addictions, long-term care home, acute care, and many others. It's really a broad network working together towards shared goals. Within that, we have more than 160 family physicians representing all of the primary care groups in our region. That level of primary care engagement is a real strength for us, especially given the province's focus on improving access and attachment. We also have over 25 community council members who bring lived experience and patient and caregiver voice directly into our planning and decision-making. Their perspective is essential in shaping work that truly reflects what matters to the people we serve. We serve a population of approximately 220,000 people. This area is very diverse, composed of vibrant urban cities, picturesque villages along Lake Ontario, small hamlets in the north, Tyendinaga Mohawk territory, and many remote areas. And each has its different challenges in achieving access to health and wellness services. Next, I want to introduce the concept of a health home, which is central to the work we're doing. A health home is essentially a person's main access point for healthcare. It's the place they go to first, a familiar, community-based location where they can connect with their primary care provider and get support for most of their day-to-day health needs. But the health home is more than just a primary care clinic. It's designed to function as a central care hub. That means it not only provides primary care directly, but it also connects people to the broader network of health professionals and wellness services. Some of those services may be located right within the health home itself, and others may be nearby in the neighborhood. Either way, the idea is that people can access them through coordinated, seamless referrals rather than having to navigate the system on their own. So the health home model is really about making care more connected, more convenient, and more comprehensive. And it's about meeting people where they are and ensuring that they have a clear, reliable home base for their health and wellness. So now that we've set the broader context and introduced who we are as an OHT, let's move into some of our priority work that has helped build a stronger health system. And with that, I will turn it over to Connor to review the first priority area.
Awesome. So thanks, Suzanne. And Suzanne did a great job at setting the stage and kind of describing the area, and a little bit about the provincial priorities, which I think is important context to understand why we're undertaking some of the projects that we're doing, because as a region, we're really trying to achieve better health and wellness for our population. But we do need to be cognizant of the provincial priorities that are our fund holders, that enable us to do the work that we do. And one key important point of this is something that we called the current state assessment. And this is one of the first projects that I participated in when I joined the OHT a few years ago. And it was really to try and assess the landscape of primary care delivery in Frontenac, Lennox, and Addington. We didn't have a single source of truth, if you will, for who was doing what work with which populations in which area. And so we took a lot of time to actually go basically door to door, bring coffee and donuts, and have conversations with all of these primary care teams to discuss, what are they actually doing? How do they identify where their priority needs are? How do they identify what program and service offerings they might offer are, and where some of their pain points were? And this was a nice precursor to some of the work that Dr. Jane Philpott has got the province going on afterwards. And luckily, we had already endeavored to understand some of these gaps beforehand. But this was a key planning tool for us in terms of understanding which different sites had which needs, both in terms of workforce, just operational struggles, how closely their programs and services matched the population that they were serving. And what this was designed to be is toward what Suzanne went over very eloquently in terms of the health home model, of understanding what should be present in everyone's health home. And there's some common principles that we likely should all follow that are very similar to the patient-centered medical home that's been around for quite some time, recognizing that individual context within specific geographies also matters quite substantially. So the specifics of what is offered in a health home may differ, just as you might have one school where everyone knows where to go for their children to access education, but there may be a special school, French immersion, et cetera, that offers certain services in a certain area, and people know where those are as well to offer those services. And this is really towards things like embedded community specialty care. And that's one thing that we're trying to prioritize at the moment, is move some of those things upstream outside of the hospital and actually have them be in the community. So with that, I'll just give a little overview of what the current state assessment tried to capture in terms of information. So on the next slide, there's a series of basically a logic model that both doctors Catherine Donnelly and Jordan Miller from which the OHT is fortunate to have as part of our newly rebranded REACH group, was previously Quest. And don't ask me the acronyms because I've got them written down. I can't pull them out of my head at the moment, but this was really about understanding these processes that health homes are engaging in towards those health home principles, some of the characteristics about their organization that might be in support of those processes, and then how they're actually contributing to the health system outcomes that we're trying to achieve, namely the Quintuple Aim. So if we go to the next slide for some of the overview of the results, or sorry, the layout of how this was conducted. As I said, this was really a process that happened over coffee and donuts, and we've got the number of questions across some core domains of the current state assessment that are presented there, just to give you a sense of the breadth of what was asked through this. And the method was really a facilitated interview, where we captured some quantitative data through Qualtrics, some qualitative data through Qualtrics, and also some other program and service delivery information through a shared spreadsheet that was guided by those who are familiar with the family health team model. Those groups have to report things like a Schedule A and an annual operating plan that sort of showcase what they're doing in their teams and what the staffing looks like, what their priority populations are. We tried to use that as a bit of a template for that and extend it to groups that typically don't have to report those types of things. So unaffiliated family health organizations, for example, who are also doing some of these things, but they don't typically collect them in any kind of standardized way. And so if we go to the next slide, we'll get into a very meaty overview of some of the results. And I've only pulled in one thing around maturity here. The text is too small to read, but these were maturity questions that were asked of every health home on a scale of we do this nearly all the time to I don't know or we never do this. And one of the things I would just draw everyone's attention to is specifically around QI. So from the top, questions 3 to around 5 or 6, everyone seems to be doing QI, quality improvement, quite routinely. But if we go down, we also evaluated how people and patients were embedded in decision making, both from a governance level and a program and service offering level. And that was based on the IAP2 spectrum of public engagement for organizations. And you can see that's where we start to see people are less confident in their maturity in terms of how those people are involved in decisions. And we ask questions at a governance level of, do you have community representation on your board? When you are choosing new strategic directions or developing a new strategic plan, how are people engaged in those processes? So those are the types of questions that were asked there. And what this lets us do is it gives us a bit of a framework to see, as part of the learning health system, where are people doing really good work and where can we help expand some of those best practices and processes that already exist to other groups that could benefit from that. We're not trying to replicate the exact same thing in every health home, but we're trying to boost the strengths of those that are doing well and support those who need support, but also figure out how we collaboratively work as a health system in FLA more effectively. So this isn't just duplicating services, but where someone has already figured something out, let's just extend that and collaborate with that group, provided the resources that they already have, and not duplicate efforts. And with that, I think Suzanne's going to talk a little bit about how we're going to try and evaluate some of these things.
Thanks, Connor. So our second priority area was developing and implementing a patient experience survey. The purpose of the survey is threefold. First, to understand how people actually experience care within their health home. Second, to assess access, support, and satisfaction across primary care teams. And third, to directly inform improvements that reflect real patient needs and priorities. The survey helps us ensure that the improvements we make are grounded in real patient needs and real patient experiences. Ultimately, it's a way for people to directly shape how care evolves in our region. All questions in the survey came from previously validated tools, including HSPN's, Health Quality Ontario's, and OH's patient experience surveys. And from there, the questions were reviewed with members of REACH, and I have the full name listed out there. I also had to search it up before putting in here, if I'm being honest, as well as members of our community council. One of the most important parts of developing the survey was the co-design process with our community council. They were able to provide feedback on clarity, relevance, and tone. So this table here highlights some of the feedback that we heard and then how we adjusted it in the survey. So for example, we heard from several community members that the survey was too long. So we went back and ensured that the questions we were asking were actually meaningful, and we were able to cut several of them to kind of make it a more appropriate length. Ultimately, the impact of co-design is really about building something with our community, not just for our community. After all that, we ended up with a 3-part survey. The first is patient-reported experience measures, or PREMs. These tell us how people actually experience primary care. Things like how easy is it to get care, whether they feel prepared to manage their own health, and their overall satisfaction. PREMs help us understand the quality of interactions and the day-to-day experience of care. The second component is patient-reported outcome measures, or PROMs. These focus on health-related quality of life across 5 dimensions: mobility, self-care, usual activity, pain or discomfort, and anxiety or depression. PROMs help us understand not just the care experience, but the impact that care is having on people's lives. And then we also included sociodemographic questions. These are essential for identifying disparities in care experiences, for example, whether certain groups face more barriers or have different outcomes. This helps us design improvements that are equitable and responsive to the needs of all communities. We've also included optional QI questions if there are certain areas that the clinics want to have feedback on from patients. So together, these components give us a much more complete picture of how people are doing, what they need, and where we can focus our efforts to improve care. For the implementation of the survey, we chose to use a platform called MyLaminin. One of the key reasons for selecting this tool is that it's hosted at Queen's Center for Advanced Computing, which gives us access to a highly secure, locally supported environment. It meets several of the cybersecurity and privacy controls required under major data protection standards, including HIPAA and PHIPAA. And the level of compliance is essential given the sensitive nature of the information we're collecting and has helped build trust with the primary care organizations. Another major advantage is that it allows us to analyze the data directly within the platform and build interactive data dashboards without needing to export the information elsewhere. This keeps the entire workflow secure and efficient. We also have the ability to give clinics direct access to their own data, which means each clinic can view their results in real time, and we can create a customized dashboard that reflects the metrics and insights most relevant to them. At the same time, we're able to also create a regional dashboard that aggregates data across all participating clinics. This gives us a broader view of trends, strengths, and areas of improvement across the entire OHT. The intention is to send the survey to patients twice a year, and we are doing a phased rollout approach. So far, the survey has been implemented at Charlotte Lake Family Health Team and the Spruce Health Hub, and there are plans to expand the initiative across all health homes in our region. And with that, I will turn it over to Connor for our third priority area.
Thanks, Suzanne. So the next priority area is really about trying to bring a lot of this together in sort of a structured and organized way and speak to some of the equity considerations that Catherine introduced in the beginning. And although there are quite a few slides here that I'm going to walk through, this isn't all work of one person. Obviously, Suzanne has been instrumental in doing this. Catherine has a funded project around this that we'll speak to as well. So it really is a collective effort. And I think we're just lucky in this region that we've got so many talented people working in this area. So why is this important at all? We've put that person-centered health home concept map up again. It's where the rubber meets the road, where this can get difficult to go from concept to reality. And that's really what we're trying to achieve. And what is one of the founding principles is something that struck me when we brought this to community councils probably about a year ago now, when we said, is geography something that you would consider important when we're designing your system? And one of the people said geography is important because it's the only common truth that we all share in the region, which I thought was quite a good summary of why it is important to look at geography. The other things that we know are from recent evidence of some of the things that were presented at Trillium 2 years ago now was the impact of distance that people travel to their primary care home, how it negatively impacts things like visits, so access and prevention, things like cancer screening. And then from Dr. Tara Kieran's Our Care study, a gross majority of Canadians feel that it's important that they live somewhere close to where their doctor, nurse practitioner, or team of interprofessional healthcare providers live or work, sorry. And what we're trying to do then is create planning neighborhoods in the region that can help us bring all of this together. So this lets us evaluate using that prem-prom strategy. It lets us use the current state assessment to say, what does this region need from a population health perspective and population health management? And how do we inform things like the provincial strategy around expansion of primary care? Where do we have primary care deserts and what are our health human resource needs? And that helps us inform the types of proposals that are put in. So the next slide, I'll just start with a bit of the foundations around how we got here. And I would point people to Catherine and Claire Kendall's funded project around this, because they're really trying to build what a foundation looks like across the province. We were, I guess, one of the lucky guinea pigs in starting sort of locally in FLA. And how do you even start to build this up from a geographic perspective? Well, we were lucky in that we also had collaborators at Public Health who use geography quite extensively in some of the work that they do. And so we started to say, well, how do you build up a map of what the region would look like? And I think the important context here is that Ontario Health actually doesn't explicitly say that OHTs are geographic entities. They do provide sort of at a postal code or first 3 digits of your postal code level, which of those areas are attributed to which OHT, but they don't specifically provide rigid geographic boundaries, which complicates this slightly. So if we go to those census-based geographies, we started with something called aggregate dissemination areas as basic building blocks, because that's something that the city of Kingston had already been using for their neighborhoods. That's something that public health was very familiar with using. And a big advantage of that is that they were relatively stable because they have roughly 5,000 to 15,000 people. And we can get lots of sociodemographic and census-based data at that level without suppression. So what I've noted here in terms of Inspire's funded project led by Catherine and Claire is they're really trying to outline the principles of how you go about replicating this process or doing this in other areas. And there are challenges that I think that group and that community of practice has identified in terms of there are overlapping boundaries. People don't respect a geographic boundary in terms of access to care. If I live on the periphery of Hastings, Prince Edward, and Frontenac, Lennox, and Addington, I'm not going to just go to one place because I live in Tamworth if it's easier for me to go up to Haliburton or something like that. So what their work is really trying to do is map out some of these basic principles. I think on a subsequent slide, you'll see that the Ontario Community Health Profiles Partnership, I think I did remember that acronym, has some of our data up on their website already. And this is all following something called the Health Commons Solution Lab Guide for mapping neighborhoods and analyzing neighborhood level data that was put together, I feel like in 2019 or around there. So if we go to the next slide, this is something that was presented just at the conference last week. And the reason we did this was because that was an international crowd at the International Conference for Integrated Care. And there were a lot of people from European countries there, and they talk about how rural some of their areas are. And so we were trying to give them the context of how large Canada and Ontario is. And when you do that, I crudely drew roughly where FLA is in red there. And a subsequent presenter, when they were talking about their rural area, said, well, I guess we might need to redefine what rural means in the UK, given the scale of the geography that the Ontario context presents. So if we go to the next slide, that's sort of a macro level. This is the general geography that we consider attributed to Frontenac, Lennox, and Addington OHT, with overlaid census-based aggregate dissemination areas there. As we said, Suzanne went over the overall population. We have some population growth forecasts based on where it went from 2016 to 2021 and where it's going up to 2031, and noting that the median age is 53 and increasing quite rapidly. Also overlaid here are all of the different health homes across the region, and these are both the family health teams, family health organizations, CHCs, and other clinics that exist, scaled by the number of primary care physicians and nurse practitioners who are working there. So you can see that there's quite a quite a density around the city of Kingston. And then we have this really interesting rural component where people are traveling quite large distances to access a health home. And that presents unique challenges for this region because what works in the city of Kingston doesn't necessarily work in rural Lennox and Addington, as an example. So if we go to the next slide, I already spoke to this, but I thought it was important to bring up again. But this was something that Community Council identified as how are we going to bring all of this together? Well, at least if we use geography, we can all be speaking the same language. So that's just why care close to home is important to everyone. I think the literature bears that out, and it's certainly something that we see echoed amongst our community members that are co-designing these things. But the tricky thing about geography is that depending on where you look, you get different answers. And so when we start at that aggregate dissemination area level, it can paint one picture, but the further down you go, it also has the potential to exacerbate inequities if we're not careful about what we're doing. It can mask some certain sociodemographic implications and social determinants of health implications around access to care, et cetera. So it just means that in order to make decisions with some of these data, we need to make sure we're asking the right questions and looking in the right place. So the next slide, I got ahead of myself, but shows really what the OCHPP group has presented on their website in terms of attachment rates across all the ADAs that are attributed to FLA. So this really describes our need in terms of people needing attachment to primary care. There are additional indicators around the social determinants that we can overlay on this. But this is the basic building block. I think Catherine posted the link to this in the chat, but the link is there on the slide as well. And this was our starting point for defining our geography. On the next slide, I think this is actually a repeat of the slide that we did earlier. So I think we can skip this one. The reason that I got into the equity side of it is because there are some things that don't look the same depending on how you stratify the data. So this graph that is a bit busy, all the numbers on those dots are the individual aggregate dissemination area identifiers. So those are the things that StatsCan gives us, plotted against their Ontario Marginalization Index quintile. So what this and the mean distance to a rostering group. So what this gives us is that we have in particular a few that are according to the total uncertainly attached population in the ADA, fairly similar, but they're on completely different spectrums of the on-marge indicator. And if Suzanne clicks, a little thing will pop up here and kind of circle that area that shows that, these are the people that have less access to an attainment of basic material needs. That has a substantial impact on their health outcomes. And they also have high unattached rates. So when we're planning a potential expansion of primary care, unfortunately, we don't have the names of them, but if you bear with me on 35.1.404 versus 35.1.406, those are completely different situations for people, even though they have roughly the same number of unattached. And so the next text beside all this, I think, speaks to some of this. And it also speaks to how we have tried to build out our proposals that the primary care action team has solicited from OHTs in primary care across the province. Is we do have family doctors working in models that don't have good access to the allied supports that some of these people that as we go into the higher marginalized quintile are going to need the most. And so how do we build an expansion of primary care that provides those wraparound supports to those doctors and the people that are already there? And we need to understand some of the programs and service offerings that are already available in these locations, and that's why we did the current state assessment. And we also need to consider the health workforce, and that's where we need to collaborate more effectively with municipalities and hospitals. The next slide is kind of driving this point home of if we count the number of attached across all of those ADAs, these are still the same ADAs, just with a different color scheme. We can also plot, because we did the current state assessment and we've got a very engaged primary care network, we know how much capacity for attachment each team has, and we know how many unattached are there. And you can see that most of the time there's a mismatch where there's either more capacity than needed in a certain place, or far less. And this is just one tool in the tool belt, but I think that's why it's important to consider the equity piece of this, because attachment isn't the same depending on the place that you get attached. When we're collaborating with Healthcare Connect to try and figure out how best to attach people to primary care, we do give consideration to the on-marge data set, knowing that if we attach someone to a family health organization, they typically have access to care that you would expect to receive from a family doctor. But they may need additional supports from something that like a community health center might be able to provide, specifically around social prescribing, or other types of things that are just going to be more difficult to access through a more standard sort of patient enrollment model. And so we do use that information when we're trying to guide decision making around where people are attached. Obviously, the overarching goal is that everyone in the end knows where they're supposed to go to access care, like you would a school. We're trying to minimize the distance that people travel to access care because the evidence has shown this. And we can say anecdotally through speaking to people through Healthcare Connect that this is actually a big driver for them. We have had people decline connections to specific groups because it was too far to travel, with noted challenges being they don't have a car or there isn't good public transportation there. And these aren't distances in the very rural locations. These are actually places even within the city of Kingston. So I think we keep hearing from people that this is a big factor, and that's why we're trying to use all of this information to make the best decision that we can at the time. I've got a little example of what we mean by this on the next slide, talking about the social determinants of health and why it's important. And so if you look at something like the amount of visible minorities we have in the city of Kingston, there is a stronger concentration of them on the West End, where there's significant growth. Why is this important for the type of primary care organizations and health homes that we're trying to build out? Well, language and culturally appropriate care in those clinics is probably going to look different than it does in others. If we look at diabetes prevalence that we have, same thing at a slightly higher scale for comparing that East versus West End, there are differences here. For the East End, we have a slightly shorter distance to the average food resource. Luckily, the city of Kingston provides, through their Insights Hub, access to where affordable and free food resources are across the city. And their average distance to a health home is substantially shorter than it is for Cataraqui Westbrook. So this has implications if you're running a healthy eating course, for example, in one of those different health homes. You can offer the course, but you also have to understand the barriers that people face then when they leave your office to actually acting on some of the advice that are being given, or even a social prescription that's being given. So these are all the reasons why, if we look at just one aspect of geography, you have the potential not to see the whole story. And I think I have just two more slides kind of speaking to this before going on to more general considerations. And this one is a cluster analysis that Suzanne and I did based on the StatsCan low income after tax indicator. And the hexagon that's crudely drawn on there is supposed to be the overall aggregate dissemination area for that location. And at that location for that hexagon, the unattached rate is 15.6%. But if you look at the clusters of where the lowest income folks are located, and you look at that unattached rate, it's higher, which isn't surprising. But the implication is that if we only looked at that hexagon, we wouldn't get that information. And so how and where we're attaching people at a neighborhood level likely needs to be informed by some of these things. The types of supports that might be present, for example, people might need help filing their taxes as a social determinant. Those are the types of things we should be considering. The last piece around social determinants of health and on access is on the next slide, where we actually went down right to the dissemination block level, which is the smallest census-based geography that StatsCan offers. And we can see if you do basically a floating catchment method access calculation, which is a unitless parameter in this case, mostly based on supply demand, and then you add in the social determinant aspect, which is coming from that marginalization parameter from the Ontario Marginalization Index, as I mentioned, you can see that you don't actually get the same result, that places that look like they have good access, just according to the model, when you extend it to include some marginalization, that then there are other places that actually increase. And so this is just speaking again to the fact that depending on the scale at which you look, the answer that you get might be different. So obviously these are all tools in our tool belt. They're all useful tools. Everything isn't a nail though. So you want to have more than just a hammer available to you. So if we go to the next one, where this is all led or where we're at right now, which are how we have created these planning neighborhoods across the region that are partially based on those aggregate dissemination areas that we showed, especially in the city of Kingston. But in the rural locations, they're modified a little bit, a lot driven by how care is actually delivered. So one example is in the Stone Mills, South Frontenac region. Those are actually two different ADAs, primarily Stone Mills and South Frontenac. We've grouped them together because they're serviced by one family health organization. So from a service planning and delivery perspective, it's much easier to coordinate if they're part of the same planning neighborhood. And so that's just sort of showing you one sort of a contextual example of how we arrived at this. And then I've circled on here three different, and you can just bring them all up, Suzanne, at the same time. Three different examples of why this matters. So refinement of the neighborhood in sort of the north area. We have one health home delivering care to that entire area. The average person is traveling at least 23 kilometers to reach a health home there. So home care and mobile access is going to be very critical to those locations. The refinement I already spoke to around Stone Mill, South Frontenac in terms of service delivery, and then in the city of Kingston, where marginalization has a big impact on how we're trying to attach and deliver care. We're also challenged because of population growth and demographics not looking the same across these locations. So using these planning areas, on the next slide, it shows a little bit about where the population is going up to 2031, and just tried to highlight two examples of one being North Frontenac and one being the city of Kingston. And we see that the growth in population in North Frontenac is predominantly in the 65 plus category. There is also growth in the city of Kingston, but there's a bit of a bimodal thing going on where you've also got a younger crowd also driving some growth there. And this has huge implications on the type of supports that North Frontenac would need to provide to people accessing care there. So working with the community, and this is where how do we bring this into the health neighborhood? Working with your community support organizations like Meals on Wheels, that's going to be a big component of how we keep people at home and living well in North Frontenac. The next slide also just highlights this a little bit further, just showing some of the sociodemographic breakdown between the two. Median age being almost 20 years older in North Frontenac, median income being substantially lower, unattached actually being a little bit better than the city of Kingston, population density being incredibly different, and average distance to the city of to a health home being incredibly different. So what access means to people in North Frontenac will not be the same thing as what access means to people in the city, directly in the city. So where are we going with all this, and really how do we tie all this in together? Well, that's where we're trying to use things like the current state assessment to build in some new layers to this that you'll see on the next slide. And I think I spoke to all of these things, but this is why it's important to consider from a social determinants of health perspective. Where we're going with this is obviously we've got lots of layers about attachment and about census-based data, because those are some things that are readily available to us, and attachment is a provincial priority at the moment. But I think this is where those other priority areas, some of which Suzanne spoke to around the current state assessment, the maturity of how we're trying to get towards this health home vision, are important next layers to this. And we're still analyzing the data, which is why they're not layers on this yet. But I think this is where we can start to get to what we're talking about better coordination and collaboration across the region in terms of making sure we're actually delivering on what the population health would say we need to be delivering on, and making sure that we're co-designing with people along the way to ensure that access is actually access as they would define it. And this is all a part of our learning health system approach. And one of the committees that we've spun up to support this is on health human workforce recruitment and retention, and another on related to health home maturity around how do we actually improve primary care effectiveness. And one of those things is because of the current state, we know who's doing what where, what's working well where. We're able to, and we've just put in an application with Queens to do some simulation lab training for specific care plans of care, so that you can actually simulate how a family doctor, how a nurse practitioner, how the other allied staff would actually support people coming in needs of certain things like diabetes management, et cetera. For the journey ahead, in the last slide, before I touch on Indigenous data governance, and this is actually what's happening this afternoon, is obviously there's lots of data out there. We don't want to reinvent the wheel every time. So how do we bring different elements of the system together so that we've got healthcare, municipalities, community support organizations, social services all together sharing data so we can collectively make better decisions? And that's what we're launching this afternoon with the help of the City of Kingston and the Southeast Public Health Unit. We had a group of PhD students over the course of this year, thanks to Queen's graduate studies, that we're working on a governance roadmap for how would we bring all of these organizations together to share data more effectively and collaboratively. The last piece that's a priority item for the REACH group and the OHT is on Indigenous data governance, because this is something that we need to make sure we're incorporating from the get-go before we do any work on Indigenous data. And I won't speak to this substantially because this is Dr. Amrita Roy's work around how we build out an Indigenous data governance framework. That said, Suzanne and I, and in collaboration with Hastings Prince Edward, because Tyendinaga Mohawk territory actually is actually partially in HPE and partially in our catchment. We're designing at the same time a work plan to understand the landscape of what's available in Indigenous data, to understand what those communities feel is important to them, to understand the barriers that they face when self-identifying if they go to the hospital, or self-identifying in other places where they access care, in the hope that we can incorporate that information in that prem-prom and evaluation strategy, all governed by the framework that Dr. Roy is putting together. So with that, I think just like to finish up by thanking all of the people here. There's many more. I think we've just brought in the people who are part of the OHT's REACH group. And yeah, thanks to Catherine and Sherry for the invite, and happy to answer any questions.
Connor, I mean, it's just impressive. I know I introduced and said what a treasure both you and Suzanne are, but truly, when you look at all of this layered work, and this is over 2 years that you've been here and 5 years of the foundation that Kim's been leading. And when I see it, I kept thinking to myself, like, this is a living lab that we've always spoken about at Queen's in terms of research, and how do we leverage our area and our uniqueness to really understand how we can look at data-driven, evaluation-focused health planning. So I just wanted to say that, and I'll open up the floor. I'm sure there might be folk who have some questions. I've got a few comments myself, but I'll leave it there. Helen had a question. Actually, I'm curious actually about that too, Helen. I'll leave it for you to speak.
Sorry, do you want me to say something?
Sure, what the heck?
That's okay. No, it's always in looking at population data in Kingston. I am curious about Queen students, particularly undergraduates. Are they included? Are they not included? And um, Queens is so large in comparison to the entire population of the area, that how does the student population potentially skew these
It's a
data?
it's a good question, Helen, and I can't speak to the city's data set specifically outside of the census-based data, which of course doesn't. So that's a big blind spot here. That's why we're trying to understand the Indigenous data, because that's also a blind spot. It's completely excluded from most of these things. And we do have had a student project to specifically look at access to care within the student population because it looks quite different. There is the Queen Student Wellness that is offered, um, but we don't have good data on that, and that's exacerbated as well because the provincial data sets that we get on attachment typically don't include in students unless they're accessing care frequently enough through the hospital that they appear in our data set. So that's where the way the province is doing their attribution gets complicated, in that sometimes people that we look at in the census don't actually appear in the attributed population data that we get from Ontario Health. And so it's not an easy comparison that way. So yeah.
Yeah. What triggered the question for me was the population profile you had for the county versus the city, and it's obvious, generally much larger, younger population in the city, and that's I was just wondering what the student influence is there. I know it's always a challenge in so many ways. But yeah, and it started a whole bunch of thoughts for me in terms of how students access healthcare when they're actually living in the city. It's presumably primarily through the university itself.
It is,
Yeah.
and we're hopefully have a report on that that's just coming out. Specifically, it was a student population, but specifically newcomers as well, so people that are new within the last 5 years, and where they access care and how they found out where they were supposed to go to
Mhm.
access care. Um, yeah, and
Yeah.
it's difficult, and surprisingly, most of them heard from word of mouth or a caregiver or a family member
Yeah.
who just gave them
I
the
see
information.
Kim's just posted a comment about the use of emergency services in the city, and that especially around homecoming weekend and and St. Patrick's Day. I mean, there have been some real horror stories. Okay, that's enough for me.
Thanks. That's great, Helen. I was thinking those comments too. Chris.
Well, thank you very much for the presentation. It was really excellent, and for somebody who's worked here for over 30 years, this kind of brought a lot of kind of real experience to life. When I think about the patients I've seen and where they've been from and what their barriers are, and from everything from, well, why didn't they show up to clinic today to why are they having difficulties with adherence to their medication, and things far more complex and nuanced than that. But you mentioned Jane's work, and one of the things about the kind of the small p political part of all of this is that there's this extraordinary focus on attachment in a tick box kind of way right now, right? Like there's this rush to get 100%, whatever that means. It's some number less than 100, obviously, attached. But I really sense that the conversation is rapidly now turning more to access, and attachment was always sort of a kind of a first step or a caricature, within the broader sort of aspect of access, and what does access really mean. And all of the data that you have really, I think, are so great for us to start to imagine how we're going to provide access in the biggest sense of the word, and the wraparound supports, and the notion that health comes from things other than just the healthcare system, and how we need to be connected with social services and so on. I found that very kind of compelling, the way you've kind of constructed the story, and your OHT is far ahead of almost all others around this, and I think really positions it very well to continue to be an exemplar for where we want to go. And then, of course, the final step, if we imagine the perfect health system in the future, and for those of you who are still optimistic enough to think we'll ever get there, would be to be in a position where, okay, we've got attachment largely sorted, we've got access kind of sorted out, people are kind of getting the care that they need through the model you've described. But now, what are the outcomes we're achieving as a result of that? And that opens up all kinds of very interesting avenues about switching all of our funding models to outcomes-based funding and so on, which arguably is going to be a necessary component of the sustainability of the system and so on. So I'm rambling, but I just really wanted to shine a lot of light on the quality of the work, the direction of the work, and how I see it really supporting policy in Ontario. And just want to really encourage you to keep up with the really good work.
Thanks, Chris. I really appreciate that. And I think we're completely aligned in trains of thought. I completely agree with the attachment and access piece. And I think I think Kim would agree with me in saying that, we're trying to do the best work we can to deliver on Jane's vision. And I think she does have a good vision. Like, she really is trying to get to that neighborhood school board approach. And I think this is just the beginning, and we're trying to do these two things at the same time, which is deliver on the tick box objectives that you're talking about, but not losing track of what we're actually trying to build, which is more what we described in the presentation. So I think as long as we keep that in mind and don't lose sight of that long term, I think hopefully we can stay positive about it.
I think that's great. And you present everything so professionally in a shine light kind of way, but I'm in the business of generating a little bit of heat too. So I don't mind using your light for heat purposes.
Yeah.
Thanks, Chris. Those are lovely comments. Kim.
I love it, Chris. And I just want to echo Connor's comments, and the way I sort of picture it and how I maintain my optimism is that Jane's work and the health homes that you've seen as part of this presentation is the foundation of the system. The rest, the integration and outcomes that matters, take a systems approach and will have to include more than just primary care. So I feel like, what you've just heard from Suzanne and Connor in the neighborhood model is here's Jane's work in the foundation of building access and attachment to primary care. And how does that then translate to the next step of how do you connect to all of the other things that keep people healthy and well? And whether that's social determinants of health and somebody to do your taxes, as Connor said, or the CSS services who bring Meals on Wheels to people so they don't have to go to long-term care, or an acute care hospital that will see somebody when they're acutely ill and have a place to send them back. They're all parts of that integrated piece that the foundation is on what we're doing, but love that we're not going to lose sight of. It's not just all about primary care. It's about how that's a foundation for the integration of the rest of the system. And we'll get there.
Yeah, I remain optimistic myself too, despite 35 years of working in the system. I always think to myself, like, it's everyone around the table here, right? It's like slowly eking the needle forward. It may not seem like we're doing it fast enough. There's so many different bigger barriers, but like slowly thinking differently. And I think Jane's vision is getting us to think and speak differently. And I think Connor and Suzanne, like, your work here really does show the possibilities of how you can think neighborhood oriented and use data to move ourselves forward. And to Chris's point, how can we have outcomes that matter to patients? And I know I'm just thinking Duncan Sinclair is always like, it's really about wellness and health, not sickness. And how do we have outcomes, wellness outcomes, so the population can see themselves benefiting from the bigger system. I know, Connor, all that work around the prems and proms is getting us there too. I'm just looking at the time, and I know people have probably 1 o'clock, so I'm conscious of just giving us a little bit of a transition, but I just want to say every time I see all of the work that both of you do, it's just so inspiring, and I'm just so grateful. And thanks everyone for joining over lunch, and we will keep everyone updated on this work as we go through. And everyone, if they need to take a look too at the FLA OHT website, there's a treasure trove of all the work that's being done regionally. And again, all the data and neighborhood work is posted on the Ontario Community Health Partnerships Profile. I can never get that acronym, but that links up there too. And this will all be on YouTube for people to check out if they'd like to. Thanks, everyone. Have a great rest of the day.